Hello and welcome to Yashoda Hospital. I'm Yojana, hosting Nursing Education and Training webinar series live on Facebook every Thursday at 3 p.m., bringing forth the most interesting topics. Thank you for joining us today. Stay tuned till the end of expert discussion. Also, you can post your queries in the chat box, which will be addressed at the end of the webinar. So our topic for today is immediate care of a preterm baby. So without any further delay, let me introduce you to the pros for today's webinar. And I take the privilege of welcoming our expert panelists for the day, Dr. Sudha Ma'am, Senior Consultant Neonatologist, Yashoda Hospital, Somajiguda. And I'm very happy to welcome our speaker of the day, Miss Nisi, Nurse Manager for PICU and NICU, Yashoda Hospital, Malikpet. So looking forward for enlightening discussion, and I request you to start over the session.
Good afternoon, all. Now let us see the classification of newborn and principle of management. Who is preterm? The baby who born alive before 37 weeks of gestation is called premature or preterm. So the classification is late preterm, moderately preterm, very preterm, and extremely preterm. So who is late preterm? Baby born between 34 and 36 weeks of gestation. Moderately preterm, born between 32 and 34 weeks of pregnancy. Very preterm is between 28 and 32 weeks of pregnancy. And extremely preterm is before 28 weeks of gestation. So we have to follow certain principles for managing these kind of babies. What care we give at birth? Prevention of hypothermia, fluids and feeds, monitoring and early detection of complication, and appropriate management. Now we go into detail. So immediately soon after birth, we have to dry the baby and warm. Administer injection vitamin K intramuscularly and assess ABC, airway, breathing, and circulation. If there is any signs of resuscitation, follow the inverted triangle. As I say, dry and warm the baby. If any secretion, oropharyngeal suctioning, maintain patent airway and provide oxygen support and effective ventilation via face mask or endotracheal intubation. If no pulse and respiration, go with chest compression and drugs. Resuscitation follows according to the condition of the baby. If less than 32 weeks or birth weight is less than 1.5 kg, require more active support. If less than 28 weeks of gestation, go with endotracheal intubation and assisted ventilation. Now, how to prevent hypothermia? First, KMC is nothing but kangaroo mother care. It's the skin contact between the mother and the baby. So why we advise KMC? The baby can gain weight, then more milk will be provided. Then the other thing is less stress to the mother. Then nesting. Nesting can be done with the food grade plastic bag or clean wrap. Then we put the baby under the warmer. So the nutrition also very important. Nutritional allowance for preterm is 3 to 4 grams per kg per day. So then energy requirement is almost 120 to 130 kilogram per kg per day. So the breastfeeding, choice of milk, express breast milk if it is available to the mother, or else if she cannot get EBM, donor human milk or formula feed can be advised. Check for any signs of hypoglycemia. So we have to go with the gestational age also. If more than 30 weeks, go with IV fluids and nasogastric feeding. 30 to 34 weeks, go with nasogastric feeding. Kadori is nothing but paladi feeds and breastfeeding. More than 34 weeks, Kadori and breastfeeding. So how to control infection? As all of us know, prevention is better than cure. So we have to follow the 5 C's is given below. First, we have to clean our hand. Then the surface should be clean. All the procedures should be in a cleaned manner. Clean the cord, and cord clamp also should be clean. We have to, nurses has a vital role in monitoring. 24/7, the nurses will be in the bedside. So clinical monitoring is very important and is mandatory, must and should. We have to check for the activity and behavior. Observe the skin color, whether it's pink, pale, blue, or yellow. And tissue perfusion also should be checked. Fluid and electrolyte balance, if necessary, ABGs. Feeding intolerance also must be noted. If there is any vomiting, gastric residuals, nothing but aspirate content from the stomach after 2 hours of feeding. And we have to observe the abdominal girth. Daily, we have to check the weight of the baby. And then check for any signs of respiratory distress syndrome, apneic attack. Apneic means total cessation of breathing more than 20 seconds, or else sepsis, and PDA is patent ductus arteriosus, a small opening of the heart, small hole of the heart. So finally, medication administration. Corticosteroids. It can be given to the mother for the lung maturity of the baby. And synthetic surfactant. It's a life-saving treatment for preterm babies who require ventilator. It can be given immediately after birth, so that can prevent mortality. Vitamin K to prevent hemorrhagic disease of newborn. Antibiotics prophylactically also can be given. Thank you all.
Thank you, Nisi sister, for this amazing discussion regarding immediate care of the preterm baby. Sudha ma'am, if you have any suggestions and the recommendation, please, it's time for you, ma'am.
Thank you, Yojana. Thank you, Nisi. And Nisi has covered most of it and she has done a good brief presentation. What I would like to emphasize is asepsis precautions in care of a preterm baby. Even though right from the birth onwards till the baby is discharged or till the baby has crossed 2.5, maintaining aseptic precautions and seeing that the baby is not getting infected is the utmost important factor in the preterm care. If you have any questions, Yojana, I'll just answer them.
Yes, ma'am, I have 2 questions from the audience. So what is the priority assessment for preterm baby?
Yeah, it's a good question. The priority assessment starts from birth. Immediately after birth, like any other neonate, preterm resuscitation, we see heart rate and we see how the baby is breathing. If the baby is not breathing, we'll just do the initial steps, then cleaning, and then take the baby in wrap and then give bag and mask ventilation if the baby is not breathing. If the baby is breathing well, then we'll just assess heart rate, color, and everything. If at all baby needs any respiratory support, we'll start the respiratory support and shift to NICU. After coming to NICU, like any other neonate or children, we have to see everything, like starting from vitals and then baby's activity, baby is dull or not, and perfusion and systemic examination. We don't want to touch the baby too many times. We don't want to introduce infection to the baby. So most of the neonate examination is by inspection and we see the monitor how the vitals are doing. If at all we feel like we have to inspect, we have to see capillary filling time and all, then we'll touch the baby.
Okay, ma'am. Thank you, ma'am. And one more, ma'am. Can a cord clamp be delayed for preterm babies? Can we delay a cord clamping?
So more than 35 weeks, we can do delayed cord clamping. But less than 35 weeks, there are no recommendations to do delayed cord clamping. Now, there are being studies done between 34 to 37 weeks to recommend delayed cord clamping, but less than 34 weeks, we don't have any recommendations.
Okay, ma'am. Another question just now. What is the main purpose of UPGAR for preterm? So does it play any role in UPGAR?
Yeah, definitely it has a role. Like a term neonatal, we definitely see how the baby is doing at birth. But there are some few lacking points. That means the baby's tone will be dull. Tone will be hypotonic in preterm babies. So UPGAR will not be like 10 out of 10. Okay, it will, even if it is a good breathing preterm also, the UPGAR at 5 minutes might be 8. So the tone is not very good. We have to keep it in mind.
Okay, ma'am. Thank you so much, ma'am. Ma'am, regarding this surfactant, so what is the role of a surfactant in treating the patient for a preterm baby?
So she has mentioned that less than 28 weeks, we directly go for intubation. Not all less than 28 weeks need intubation. But if there is significant distress, we immediately start a delivery room CPAP only with neopuff. And after going to NICU, we connect it with the CPAP machine. On CPAP, there are certain settings. If the baby is requiring more than 30% of FiO2 and the distress is significant, then only we go for surfactant.
Okay. Thank you so much, ma'am. And please join us next Thursday for yet another interesting topic with more eminent speakers. If you enjoy our webinars, please share them on social media using the hashtag Yashoda Hospitals Nursing Education Training Webinar Series. Also, tell us about your interest in the Facebook chat box. So we will definitely come up with the same. Stay tuned and keep smiling. Thank you.
Thank you.